Steve, as you know, there's so much emphasis being placed on comparative effectiveness research these days, and there was an interesting study reported in looking at the monotherapy in Alzheimer's disease versus a double therapy with donepezil or with donepezil and memantine. And actually, I was wondering if you could kind of review those results with us and the approach that they took in trying to address this question.
Well, it was an important study, exactly what you said. They want to, are we really getting added value of adding a second drug? And they took advantage of pooling data from 4 other studies, which gave them a large N, a large population in order to study. And so they had, by pooling these 4 studies, they had a huge number of patients. I think 567 were on monotherapy and 841 were getting both therapies. So what they found was very interesting.
So it sounds like they took data from multiple studies, kind of combined the data, and then looked at the comparative efficacy of either the combined approach versus the monotherapy approach. And so what was the kind of take-home message of the results?
Well, first of all, each drug individually works. Donepezil was a little better than memantine, but both of them were more effective than placebo. But even more importantly, the combination therapy was better than each drug individually. So there was advantage in giving both medications.
That's interesting. So I think the practice generally here in the United States is to, when patients progress, they're started on this, anticholinesterase inhibitor, usually donepezil, and then as the symptom progress, they do add memantine. And so it sounds like it's in some ways, at least in the United States, a confirming study that actually the stepped approach of donepezil and adding on is actually probably beneficial.
I think so, and then it raises the whole question, should you start both right away? Because if you really have added benefit from the 2, why are you waiting? Since they have different mechanisms of action, one is a cholinesterase inhibitor and the other one's an NMDA antagonist, and so you ask yourself, should you really do both right from the scratch?
And so this is comparative effectiveness, but how about the concept of cost effectiveness? I know in other countries they're actually kind of restricted from using both medications, oftentimes in Alzheimer's patients, because of the extra cost associated with it. And kind of your thoughts on, we've talked a lot about the cost effectiveness of medications, how we think about that, but any thoughts on those kind of?
I think we need more data on how much of a benefit we got. I think we know that it was either one was better than placebo and both were better than one, but how much better and what's acceptable for what we pay. It's like anything else. If we're on the steep part of a curve where the benefit is great for the amount of cost, it's certainly worth it. But if you're on the plateau at the top, where the incremental benefit is very small for a large cost, then I think we'll question whether that's the most judicious way to use limited resources.
I agree, and I think even though I think it's confirming to our practices that the combined approach in severe patients with dementia patients, I do think we continue to have to be mindful of the extra cost, and I think as healthcare reform unfolds, there may be kind of additional things that we have to consider when we're prescribing medications, including patients with dementia.